Good afternoon, everyone. I think after lunch, we are ready for another regeneration and another aesthetic gynecology session. So, we are talking of ovarian rejuvenation, endometrial rejuvenation, and followed by medico-legal. Dr. Nandini, specifically because they are in this field, so she will be giving us what we can do, what we can't do, national as well as international guidelines on that. Okay. So let's talk of ovarian reserve. We know that we are all born with a very fixed number of oocytes at birth, and this is decided not even at birth, it's decided in utero. And it is only, and how different are men and women. Women, you can see we are born with about 70 lakhs, and then we become 4 lakhs at menarche, and only 1,000 at menopause. At menarche, our numbers have reduced, while in boys, they actually mature during puberty and they start producing these sperms then, and then they keep producing all life. So we know that, ovarian insufficiency is something and which is becoming very, very rampant. As a fertility practitioner, I don't know, and I'm sure we can all share that even 29, 30, 31-year-olds are coming with AMH as less as 0.5, 0.7, 0.9. And nobody has an idea why is it reducing so drastically? What is the real reason? Is it something to do with our food? Because that's what I think is stress. I don't believe is the only factor, because it was here, it was there, it will always remain. There is something which has undergone a drastic change, and probably pesticides in our food could be one of the factors. So anyway, what do we call, when do we call ovarian insufficiency or premature ovarian failure? Is when you have menses stop before 40, or you see an elevated FSH level more than 25, 2 occasions, 1 month apart, then only you can say that somebody is having a premature ovarian failure. And of course, the E2 levels are low, AMH is low, and FSH is high. So what do we do? What can we do? Of course, HRT is something that all of us are used to. If somebody goes failure, then you can always put her on HRT. There is something which is new, which is called in vitro activation, which I'll be talking out. Mitochondrial activation. We know that energy is all stored in the mitochondria. So can we activate the mitochondria? Of course, stem cell, exosome, and PRP. These are the 3 things that we've been talking in the morning, and we'll also be looking at it again. And, biomaterial strategies which can also be employed to combat this problem. So let's talk of in vitro activation. What can we do to augment, for the residual primordial follicles in the ovaries which are there? So we all understand one concept, and that is every single organ has got some stem cell, or which is called the niche, and which can be activated by one or the other method. So how do I put it into practice? One is, of course, we'll be doing that stem cell. That will remain our main, practical area. But there is something called in vitro activation, and they have found that by doing a methodology of taking out a cortical tissue of the ovary outside in vitro and putting in substances like P10, P13K, activators and inhibitors, they have found a cocktail which can activate the primordial follicles, and once put back into the body, it can activate, and it can, we have seen the results, which I'll also be showing what we can do. So this is a drug. There is another thing called a drug-free IVA. And I don't know whether I have seen that, some patient who came to me with 20 years of infertility, I tried doing an IVF, I failed. Okay? She was around 40, 41. But next month she came pregnant. So somewhere is the hippo pathway that we have, maybe the needling did it, whatever. This is where what we don't know, but somewhere we are interrupting the pathways which are activating the stem cells and then getting them pregnant. So this is a methodology, and see if you can see here, this is what they have practiced. They've either removed the ovary or fragmentation of the ovary, strips into cubes. They have cryopreservation, giving shock to the tissue. Whether it is cryopreservation, mechanical shock, chemical shocks, but somewhere you are doing something to the tissue. So fragmentation of ovarian strips into cubes, this is what is causing the hyposignaling disruption and transferring this activated ovarian tissue back into the pelvis. And they have found that, they have tried retrieving mature eggs and doing an IVF and doing an embryo transfer and getting a pregnancy back. So by putting these AKT stimulators and inhibitors, they have used this to activate. Okay, the next is mitochondrial activation. Can we activate the power source of cells, which are the mitochondria, which are regulating the calcium signaling, the redox potential, the apoptosis? So we know, when there are no mitochondria, there are more of ROS and there is apoptosis of cells. So can we, nutrient therapy, and I think coenzyme Q10 has already been proven to be one of the methods of activating the mitochondria. Resveratrol, melatonin, rapamycin, these are the other substances which they have found can activate the mitochondria. Another is mitochondrial transfer therapy. Can we do that? Autonomous germline mitochondrial energy transfer. Can we take out the mitochondria of the cell, put another mitochondria? But remember, mitochondria also has a very small amount of chromosomes. So there are some kind of diseases, and I have faced this once, in a stillbirth, when we found that she was actually a carrier of a mitochondrial disorder. So we know that that can be one problem, but otherwise autonomous transferring of, changing the mitochondria of the cell can be another way to activate the cell. Well, coming to stem cell, and I'm sure, from morning you've been hearing about stem cells, and again, as we said, that every single organ has got stem cells, which all you have to do is activate. And we have so many experts in stem cells today, which will be talking more about it. It is not only the cells which, which will find to activate, that is paracrine. So there are stimulation of growth factors, which will also cause a change in the, and exosomes are small, very small particles which are released when culturing is done. And today we heard about it, and this has been extensively being used in cosmetic creams. But exosomes, because they are not only cells, they are not. In fact, they don't have cells, but they have messenger RNA and microRNA, which help in communication. And probably in recurrent implantation failures and recurrent pregnancy losses, where you don't know why the embryo and the endometrium is not having the right crosstalk. So in fact, we have, with advances, we have been doing this study in which we are giving exosomes IV and doing a PRP of the ovaries. So we are combining the two technologies to see whether we can do something about it. So again, talking about stem cells, and there are so many types of stem cells which we are all know. Embryonic stem cells is something which is the inner cell mass of the blastocyst that we see. We know this is a full baby, so we know it can form anything, but its clinical application is restricted and it can have an immune rejection. What about the mesenchymal? So we heard since morning, cord blood, bone marrow, adipose tissue. Adipose tissue is so easy. Just liposuction and you take out the fat, create nano fat, and then you can use it wherever you want. So mesodermal derived tissues such as bone, cartilage, adipose, and muscle, and these are multipotent. So there is a difference between a pluripotent and a multipotent. So mesenchymal stem cells are multipotent, where no ethical concerns are there. It can be widely used, and there is no immune rejection at all. What about spermatogonial stem cells? Again, derived from the testicular tissue. Again, they are pluripotent, no ethical moral concerns, widely used, yes. And induced pluripotent stem cells. Well, these are, I think, what we'll have in near future. Human somatic cells, you can differentiate into derivatives of any three layers. They are pluripotent, no ethical concerns, of course, and the moment they will get a clearance, I think we'll start using this much more. So I was talking about the ovarian niche. So as I said, the stem cell niche is the microenvironment where the surrounding stem cell will survive, and they have all the substances. So senescence starts when an aging of organs starts, then this niche is what will come into vogue. So female germ stem cells or ovarian regeneration, as we say, you want to mitotically activate the germ cells, and then they can be purified, cultured in vitro or in vivo, give rise to oocytes, and at least restore the normal hormone levels, and possibly, and I will agree with Dr. Jain ma'am that I don't know how many pregnancies will happen, but definitely there is a hormonal change, and that probably is some of the change that we have seen. So these are the studies that they have done, after taking umbilical cord mesenchymal stem cells, and they have seen, and this is, instead of reading out all studies, in most of them you will see that there is a slight increase in AMH, E2 levels, decrease in FSH, and this is all, and some of them have started menstruating. So they have seen that women who stopped menstruating, once they were given stem cell transplant, whether it was bone marrow or menstrual stem cells. So we all know that menstrual blood also has stem cells, and in between it had gained a lot of momentum. And amniotic fluid. Another, area of interest is amniotic fluid stem cells, which can also be used for transplanting. So again, I'm not talking of embryonic stem cells because this is something that we anyway can't use. Let's talk of something which we can use, and this is the induced pluripotent stem cells, which I also talked of. How you can, by putting in all these substances, you can develop a germ-line cell and then oocyte-like cells, spermatid-like cells, and probably one day get into the area of a genetically producing offspring. So we are, of course, doing more of, either adipose tissue or stem cells or PRP into the ovaries. And not only will they start, as I said, ovarian function, the cytokine, the paracrine mechanism, but will also specifically, not only in ovaries, but in endometrium, prevent inflammation and immune reactions. So how do they do? How do they activate? All the progenitor cells which are present residing in the ovary, because of the stem cells that we put in, start secreting the paracrine factors which are causing antifibrosis, angiogenesis, anti-apoptosis, and immunoregulation, and these are the mechanisms by which it can cause. So this was 4 cases of POI, which were taken, and autologous stem cell therapy was done. 4 of the patients showed spontaneous conception. This is one of the study. Another has reported, again in cancer patients, a year later patient reported normal menstrual pattern and spontaneous pregnancy. Bone marrow was done, obtained by apheresis after GCSF. If you give GCSF injection before you take out the stem cells, so what GCSF does is it mobilizes the stem cells from the bone marrow, and you get a much better sample when you do either a stem cell or a PRP. So we always give an injection of GCSF before doing that. And another postmenopausal women who developed, who had a live birth. So this is another study in which autologous bone marrow mesenchymal cells in 30 women was used with a range of very broad age they used, and the medullary aspiration of iliac crest injected in ovary, and 86% showed hormonal improvement. So the non-invasive method, that what I talked of, is in which you give GCSF, and they give 5 injections starting with -4. That means 5 days before you start -4, -3, -2, -1, and 5 days after injection you can take the blood and venous access and then draw the cells, and then you will find that minimum 50 million of CD133 plus. So as we are saying, markers of stem cells have to be noted, that whether we have the right cells that we require for ovary or endometrium, whatever we were using. Others, of course, the invasive method in which Jamshedi needle, Dr. Rajput had shown in the morning, and he'll be talking again, in which a 13-gauge Jamshedi needle is pre-washed with heparin, is put into the bone, and marrow is aspirated, and around 15 ml of stem cells derived from this isolated, and then it contains mainly stem cells, which you can see by a flow cytometer, and usually it is 5 to 15 million cells of the final product, which we can then either intrauterine into the endometrium, which Dr. Jyoti will be talking, or into the ovary. So I will just show you some of both the techniques that we have done. This is of course retrieval from the bone marrow, islet crest, centrifugation, isolation of these cells, and you can see the buffy coat again containing it is way of preparation and reprogramming it into stem cell banks and transferring it into the ovary just below the cortex. You can give this injection. I will show it on the video also. Well, what does the law say? I think I'm going to leave it to Dr. Nandini to talk about this because it's an autologous therapy, whether it requires a new drug application indication and does require approval, and from which committee, she will talk of this part. So I'll just show you the video of ovarian first. This is laparoscopic. So on all the surfaces, just going under the cortex and injecting the other ovary. .5 to 3 ml each ovary. So this was laparoscopic, and yeah, this is the this is how we have done a pickup, and after pickup we are doing so same needle. After we've done the pickup, we've just removed the we've just pulled it as much as we can. Just cut the very close to the needle, inject, attach the syringe, which you will see, and then inject it into the ovary. Was a 46-year-old woman. Her son had died, and she wanted to try with her own genetics. She had endometrioma in the other ovary. Okay, so what has been the results? So if you see that a 40-year-old woman, as we said, premature menopause for 5 years, unable to conceive 4 ml of PRP was injected into each ovary. FSH, AMH, LH, everything done 6 weeks post-injection, and you found there was a change in. Now this one, they have, confirmed a clinical pregnancy, however terminated at 5 weeks of gestation. Another, they recruited 120 women with both POI, POR, and who were menopausal or postmenopausal. 4 ml of calcium gluconate activated PRP was injected into each ovary, and 13 out of the 30 menopausal were described positively responding, noting 1 spontaneous pregnancy and live birth. Another study, and you see they are all 218, 19, 20, so very, very recent studies. Injection of 4 ml activated again in 3 women, more than 1 year of amenorrhea, and they found that within 2 months post-injection, naturally conceived and has, going on to the third. This was 2019 study. Another multiple high-grade M2 oocytes were obtained from 5 ml PRP activated by calcium gluconate inserted, and who then developed a clinical pregnancy also. So again, these are, fresh studies from 2012. 311 women diagnosed with POI went into intraovarian injection, and this was, again, they saw that 87 did not develop antral follicles, 57 developed embryos, did have an embryo transfer, 9 resulted in sustained implantation or live births. Then another implantation of thawed cryopreserved ovarian tissue. As I said, cryopreservation itself is also a shock to the ovaries. So implantation of thawed cryopreserved ovarian tissue in a 30-year-old woman who had had bilateral oophorectomy at 20 years of age. Tissue was impregnated in a PRP gel and surgically implanted into the broad ligament, and growth factors were all given. IVF-XC was done, and 2 day 2 embryos she just delivered. This is an old study, and this was a live birth. So as you can see, another 12 women and 33. So these are the studies which are there. Resumption of folliculogenesis, post-PRP, resumption of menses in people who stopped menstruating, development, and some of the pregnancies that have been reported, which is what I think what we gather. Thank you so much for giving me this opportunity to talk on this subject. Thank you.